And let's get started. Welcome to day 4 of Migraine Headache Awareness Week. The days are flying past, but we are very excited to have you here. We're going to be talking about concussion. We have 2 amazing experts that are going to be speaking about this topic. We're going to have Australia's leading concussion expert, Dr. Rowena Mobbs, being interviewed by an ex-professional or a retired NRL star, I should say, a professional football player, Brett Kearney, who many of you may know, particularly if you're an NRL fan. But before we get started, we'll give people a minute or two to join. I know we're just coming up on the top of the hour. We'll give people a minute or so to get settled. But if you can see the purple woman here, you're in the right place. If you've been here before, you know the drill. I would love to kind of welcome you live on the webinar. I'll welcome sort of the first few people that can put their name and location down. And we'd love to kind of welcome you while we wait for others to get started and to join. And if this is your first time, welcome. It's great to have you here. We're really excited. We've got some fantastic experts. We'll be kicking off in about 30 seconds. Leslie from Bexley North, you are the first person. Welcome. It's great to have you here. Lynn from Torquay, I keep mispronouncing it. I didn't catch the right pronunciation last time, but thank you. I know you've been here over several webinars. It's great to have you. Steph from rural SA, Jessie from Adelaide, Jan from Sydney, Linda from Brisbane, welcome. It's great to have you all. We're going to make a start because I know that we've got a lot to sort of communicate and a lot to go through today. So let's get stuck in. Make sure you have a good connection. We're going to be streaming live video and audio. You want to hear and see me clearly. If there is any sort of buffering or connection issues, I would suggest closing down any other programs, turning off the TV if that's streaming. And if you need to, you can rejoin the webinar. That's absolutely fine if you're having connection issues. To tell you a little bit about Migraine and Headache Australia, we are a national registered charity that really has 3 main goals, and that's to fund research, to provide trustworthy, reliable information, which is why we're here today, and to advocate and support people living with migraine and headache disease. And before each session, we've been talking about some of the things that we've been working on. And recently, there's been a lot of news. And we've been talking publicly and speaking at forums and speaking to employers about migraine, about brain health, and about headache. And for some of you that saw the news last night, there was also a report that was released by the Senate on concussion, which is very topical and good timing considering that we're right in the middle of Migraine Headache Awareness Week. So it is a very relevant conversation to be talking about concussion today. So, are you in the right place? If you have migraine or headache, if you have had concussion or head injuries, if you're a parent, partner, or caregiver of someone who has, if you'd like to connect with others like yourself, or if you just want to ask a question to the expert or to Brett Kearney, then you're in the right place. Now, to connect with others like you, we have a support group. I know that not everyone is a fan of Facebook, but it's one of the best tools that we have available that's free. We have nearly 4,500 members, and there's been a lot of conversation after each of our webinars about the content and the topics and questions. And so if you want to continue the discussion, you are more than welcome to join us there if you haven't already. And if this is your first time to a webinar, welcome. If you've been to a few of these, we love to see reactions like thumbs up and smiley faces or celebrations. We really appreciate your feedback during the webinar. You can ask questions. You can send messages in the chat. If you find any of that distracting, you are welcome to close the chat. You do not need to view the chat as you listen to the experts or the presentation. There's lots of options there for you, but none of them are absolutely required. And so moving now to the people that you're going to be seeing today or hearing from. So first is our moderator, Anik. She's been with us this week and for the last 3 years. She's a big part of our content and development and online team. She is involved with the website, newsletters, If you've been reading our emails or been on our website, chances are you've read quite a bit of what she's written. And she's also heavily involved with our sister organization, or I should say our parent organization, the Brain Foundation on Brain Disease, Disorder and Injuries. And so you'll see her in the chat box, so you can say hi to Anik. There's also myself. If you haven't sort of tuned in before, I'm sort of the MC of today's webinar, but the interview will be done by Brett Kearney to Dr. Mobbs. I've lived with migraine myself. I've had quite a few concussions. I'm pretty sure that my concussions have helped develop migraine in a not so helpful way. But I'm very passionate about supporting people that live with migraine and speaking out and advocating where I can. And so on the left-hand side, you can see some of those speaking opportunities that I've taken on media and in person at events. And I lead Migraine and Headache Australia. The real experts that we're going to be speaking to today are Brett Kearney and Dr. Rowena Mobbs. And Brett Kearney, who you may also know as BK, is his affectionate nickname, is a retired rugby league and football star who's represented country origin and played for the South Sydney Rabbitohs and the Cronulla Sharks and other clubs, and played in the Super League in the UK for a period of time as well. He is an ambassador for the Brain Foundation and its mission to fund brain research, and he's helping to raise awareness for brain health and promoting the importance of research into brain disease, disorder, and injury. So we're very lucky to have Brett on board and with us this morning. And we also have Dr. Rowena Mobbs. Rowena Mobbs is a leading clinician and researcher and advocate for concussion and CTE in Australia. She is perhaps the leading expert on this topic. So we're very, very fortunate to be able to hear from her. She does a number of different things regarding her research. She practices, she's a neurologist, the principal neurologist at Harvard Neurology Group, leading a team of specialists. She has a vision for the better management of concussion and dementia in Australia, and is a crucial person in the national discussion on concussion and mitigation and management of concussion. So we're very lucky to have her here joining us. So without further ado, we'll now switch over to the interview.
Firstly, Dr. Mobbs, it's a pleasure to meet you. I've been following your work, especially more recently, so to have the opportunity to speak to you really is a pleasure. I guess to start and give some context to the conversation that's about to take place, that I should provide my history of head injuries. And I say head injuries because I thought of a lot of my injuries in the past as head injuries and not so much brain injuries. So the first of these took place, I was 12 years old and I fractured my orbital. At the age of 18, I broke my jaw. Second time around, I broke my orbital at 19. I can't recall at any stage throughout those, I guess, junior years, so to speak, where my brain health was actually discussed. It's certainly not something that's part of my recollection, and I went on to have one at an old age of 31 where I fractured my cheekbone. Again, at that stage, I was becoming more aware of brain injuries, and I started to think things more through as brain injuries, and was definitely more aware of concussion. But the concern with, I guess, where I'm at now is the junior years where I was having those traumatic injuries, that there was nothing mentioned about my brain health. Firstly, what is the difference between, I guess, a head injury and a brain injury?
Absolutely. I think that's it's a question I've often wanted to ask athletes. Actually, you've got a fracture, that can actually in itself form what we call a distraction injury. So the doctors treating you or those around you think, oh my goodness, it's a fracture, let's get to that first, and then can often forget about the other things. They should be doing a secondary survey, or in the case of a brain injury, that should form part of the primary survey. So checking for signs of concussion, but also for moderate traumatic brain injury and red flags, we would say. So red flags are those signs that might indicate something more serious, like a bleed in the brain. So that could be a deteriorating conscious state. You're on a slide, as presumably as bleeding or swelling can get worse in the brain. Stumbling and ataxia, we would call it. So an incoordination, inability to walk, persistent vomiting as well. So you can have nausea with concussion, but vomiting is a sign that there's something more, a bleed within the brain, and there are other red flags. So you can have a head injury, but I guess when you have a fracture, as you did, or fractures, one would think, goodness, that's quite a high impact. And did you have any features of concussion? Now, we divide features of concussion into signs and symptoms. So signs are something easily seen. So that could be a loss of consciousness, knockout. That's what most of us think of. But it could be a slow to get up, slowness of movement, or wobbly on your legs, stumbling or swaying. Could be a poor response, slowness of response, confusion, staring, abnormal state of consciousness. And then the symptoms are much wider than that. So nausea and vomiting is one, but light and sound sensitivity, dizziness, seeing stars, sparkly vision, tinnitus ringing in your ears. And sleep and mood disturbances can then be delayed and come on later. Headache, of course, is one. So I'd be interested to know, with those head fractures, did you have any abnormalities like that, stars, confusion, any symptoms other than a knockout that might be a concussion?
Funnily enough, I can't really remember. I know that sounds silly. Not at any of those times did I lose consciousness. Mm-hmm. The one that probably affected me the most, where I realised that I was concussed, and it wasn't until afterwards, was when I did break my jaw. That evening, I became ill and started spewing. But again, I don't think I had the education on actually what concussion was at the time to realise that was a symptom. I'd actually went home and had a couple of beers with my mates. So sort of, when I was feeling unwell, I was thinking, oh, that's odd. I've only had a few beers. So it was, I think, a lack of education around those early years for me to actually understand what to even look out for. The stars in the eyes, and this is what I'm finding really interesting now, the stars in the eyes and the sensitivity to light. I look back at games that I was playing in and can't remember being hit, can't remember any activity that would have caused a concussion, but I vividly remember looking up at the lights going, gee, they look blurry tonight. Something's wrong with the lights. It's not me, it's the lights that are off. And seeing stars, not for a long period of time, was, again, just felt like part of the game. So I'd be hit, I'd get up a little bit rocked, might not have been hit physically in the head, but takes a couple of breaths and a bit of a look around to get my bearings back. So that's where I found it really interesting, the difference between the head injury and brain injury. And it probably wasn't till quite recently, if you ask me how many concussions I had, I might say, oh yeah, half a dozen, maybe 10. And in actual fact, it's probably many, many more. The one that really does stand out to me, which I think that sort of ticks, not in a nice way, but ticks the boxes for what you went through for the symptoms there, was in the UK over the Easter weekend. You play multiple games in a very short period of time. So we played our first game on a Thursday night where I copped a pretty innocuous bit of a hit on the chin. I don't even think there was a penalty. I was falling down, got up, it was half time, and at half time I was a little bit, as I said, a little bit starry, but didn't think anything of it. Played the rest of the game, nothing else said. Backed up to play, that was the Thursday night, backed up to play on the Monday. And what happened in that game was the most scary experience I had throughout my rugby league career. I can't recall any hit. I can't really recall the game, but I had vivid memories of not knowing what position I was playing. And actually feeling like I knew what actions were about to take place. It was almost like an out-of-body experience. Must have still been doing my job because I didn't get taken off the field. I can't really remember telling anyone I felt bad. I was just going and doing my thing, I guess, what I'd been trained to do. After the game, one of my teammates had called my wife to come and get me, and I missed the after-match presentation to go home and rest. What happened that night was where it became really quite scary. I was trying to have a discussion with my wife and tell her to, I think I wanted her to turn off the light in the living room, and I was asking her to shut the lamp. So we didn't have a lamp. There was a door nearby the light switch, and I became quite frustrated when she couldn't shut the lamp. So that was my first real time, I think. And at this time, I must have been sort of late 20s, where I thought, this is a concussion. This is
absolutely very classic features for sure.
And I think once the whole education piece, which I think was lacking at the time, I think we're getting there more now. Obviously, there's a lot more to be done, but I played the next weekend, and it was the only time I ever walked onto a field scared, thinking there was something wrong with me. I knew deep down there was something, and thankfully I just went out there and the game went as normal, and now it's a story to be told. But with my deeper understanding of what could have happened, I guess, now it's totally irresponsible and quite a scary situation. I think one thing that this all leads around to, that story, is after a game, if you have a hamstring tear or a muscle injury, you ice it, you rest it, you go in for scans the next week, and you've got protocols to follow to get back on the field. I just don't know that they exist with head injuries, or if they do, I still don't know what they are. Do you have anything that you can shed light on there as to what needs to happen after a brain injury takes place?
Sure. And I guess it's really important, I think, to highlight the difference between a hamstring injury or other bodily injury and a head injury is that you may be unaware or lose insight into the degree of your injury, or that you even have a head injury. You may lose awareness of that just by the nature of head injury, of course. I mean, you sound like you've experienced a bit of that. Those around you might have seen that you were more unwell than you realized. And so therefore, although education is very important and recognizing your own symptoms, the onus is on those around you to provide boundaries and remove you under protocols, I feel. You cannot expect a head injured player to manage themselves well, in simple. So in answer to protocols, well, it seems like a lot of sports have different protocols, and this has been a great source of frustration for those athletes around the country, especially those who play multiple sports, or parents with kids in multiple sports. How do we get some consistency across the board? And there have been different efforts, both here and internationally, to add some consistency and set protocols. There is a tendency now of increasing conservatism and more time off, time for recognition and time out. If in doubt, sit it out. I think that's a really good paradigm. You do not want to go back on the field, particularly as we do recognize if you have a second head injury within a short space of time, your outcomes may be worse. And very rarely, not to alarm viewers, there is this risk of second impact syndrome, which is life-threatening. It's often lethal, where very rarely people can have swelling in the brain from a second concussion, and that can lead to death. So we want to avoid those sorts of risks. And so taking time out, not going back on, not drinking after the game, that's one for sure. Having a close watch for those red flags and being assessed in a for medical environment, if you can. Emergency often can be a good way to do that, although we don't always want to have repeated head scans, CT scans for people, but we certainly want to have medical assessment where we can, and a very close observation, and being monitored by your general practitioner is a really good step. There will be evolution of these protocols, I believe, in Australia to be more consistent and standardised and clear for people. Internationally, if you look to the UK, now they're looking at 21 days away after a concussion rather than going back the next week. And I think that's the sort of trend that we might see here, a bit longer than 7, 11, 12 days off, this kind of time. We should treat it a little more like a hamstring tear, and a little less the way we have done the last 30 years, where you'll be right, mate, back on you go. And so I think that things are changing, and we also recognize the delayed symptoms. So you had delayed symptoms, BK, just sort of late in that day, but you could have got delayed symptoms 3 or 4 weeks later after your concussion. It can be that delayed.
So, and if that's the case, how do you bring it back to the concussion? If you're all of a sudden getting you're a little bit slow or a little bit blurry 3 to 4 weeks later, how would you tie that back to a concussion from potentially 4 weeks ago? And especially if you're playing sport week in, week out, it would be hard to identify, wouldn't it?
Well, that's where you do have that, hopefully, medical care, a GP or a doctor who knows you, a sports physician, who can say, yeah, you had a really nasty concussion that week, and could your headache and confusion and light and sound sensitivity or sleep disturbance now be related to that? Well, absolutely it could. And let's institute some measures now, get you on a graded recovery plan, both to study and activity and sport, get you neurophysiotherapy or a multidisciplinary team, get you maybe some input as well, if it is headache, for managing headache and migraine syndromes, managing mood, and that the real holistic care can make a big difference going into the longer term.
The 21 days in the UK, so I know some of the codes here in Australia, it's 11 days, 14 days, it's a bit variable around that time. What's the science behind these timeframes? Is it more of a, we know we need to do something that seems like the right amount of time, or is there actually research that says, hang on, 11 days is going to prevent further effects by giving you that rest period?
There are different layers of science to this. So one layer is we have studies that have performed MRI scans, for example, which are very good detailed structural pictures of the brain that show the vast majority of patients with concussion do not have any abnormalities on those scans. Okay, that's one reassurance, but then you've got a proportion of people who clearly have symptoms that are ongoing, that might be persistent or delayed. We used to think that 10 to 15% of people had persisting symptoms. Now we have studies that show it could be more, 30 or 40 or even 50% of people can have symptoms months after a concussion. So we now know that although we use reassurance and wishful thinking, you'll probably be fine after 2 weeks, it may not be the case for a percentage of people. So this 2-week thing, it was a little bit of hope that you will recover, most people recover. It is still that most people recover, but boy, there are a lot that don't. And maybe that microscopically the brain needs longer. Ultimately, BK, we just don't have a window on the brain or a magic test that can say you still have microscopic injury and you need longer. It's not like a scan that can show muscle damage or a cartilage tear or whatever, and you need some more weeks off. We just don't have that biomarker. It will come through. There's a lot of science in this, and I think within the next 5 years, we probably will have something useful in that regard. But we're not there yet. And so that's where we need a precautionary approach and longer time off for full recovery and a really slow re-entry, I would suggest, given it's our brain. It's so precious. And it's part of good performance. Hey, we want to be right when we get back on the field.
Yeah. And even just not on the field. I mean, I went to the snow a couple of weeks ago and took a tumble on the snowboard and had to get my bearings afterwards. And again, now I'm starting to learn more. I sat there and went, okay, I'm probably a little bit off. Still got to get down the mountain. I'm not going to be doing any contact sports for the next couple of weeks, so I'm fine. But is there something straight afterwards that you can go, do you sit in a dark room? Do you do some breathing? I mean, is there anything that if you take it that goes, this will help your brain recover short term?
Well, we know that too much rest is a bad thing early on now. So the latest is to keep active, not necessarily high activity, things like gentle walking, gentle re-socialization, relearning, but in a really graded fashion. So the one thing you do not want to do is sit in a dark room for a week and just stay in bed. That could be very, very much negative for your recovery. But you can work with your, as I said, physio GP, your team to gradually get back to activities. We can manage symptoms often very well. So headache, sleep and mood disturbance are key targets very often. And there's lots of neurophysiotherapy work, balance work, retraining vision and other approaches that can be had. Lots of relaxation around tension factors of the head and shoulder, neck, shoulder and musculature as well. Also whiplash factors. So Often when you have a concussion, you may have a whiplash if it's been a high speed, or a whiplash can associate with indirect shaking of the brain and concussion. You don't have to have a direct bang to your head to have a concussion. It could be whiplash concussion. And so managing neck or cervicogenic, we would call it, factors to recovery are really important. Avoiding alcohol, not driving if you don't feel up to it, just managing an integrated approach is super important. Yeah.
So me telling my wife that I can't do chores for a week after the snow wasn't a factor.
That wasn't on, sorry.
I guess one now I've got 2 young daughters, and like I said, it's become more of a concern. What is there for me to identify at this age if there has been any? Okay, well, I'll change that. There obviously has been some brain damage done. So how do I identify what that is and put protocols in place now to help the longevity of my brain health?
Oh, good question. It's the key question, isn't it? So a handful of concussions, 1, 2, 3, 4, 5, probably most people will recover perfectly well from the brain perspective, especially young people. The young brain can do very well. So we don't want to walk around in life thinking we're doomed, we've had permanent injury. Very much the chances are in your favour of you will be fine, your brain has recovered, and you will do well in life. A moderate head injury can be different if you've had a big bleed in the brain. Obviously that can have an impact for lifelong and risk factors for dementia down the track purely and other things. But I don't think if you've had a handful of concussions, we should go through life worrying. We should still climb trees. We should still take, activities that could have risk of head injury in a week, because we need a balance in life. And these activities can improve our well-being and our vascular risk. We don't want vascular dementia either. Where things can be tricky now is that we know about subconcussions. So this is the tackle after tackle after tackle, or the repeated head injuries without symptoms. And we're talking about tens of thousands of hits, tens of thousands of potential microscopic injuries that add up for G-force and, acceleration on the brain that has association with this chronic traumatic encephalopathy that we will talk more on. So that's tricky. So, what is your accumulated burden of subconcussion is now the key question. Concussion can be life-altering, but it's a different question to CTE and subconcussion burden.
Okay. You touched on CTE.
Mm.
What is CTE?
Yep. Well, it's an abnormal buildup of protein in the brain, this protein called tau. That builds up in the valleys of the brain. We all have these folds across the surface of our brain. We know in the depths of those valleys and crevices or folds, tau protein builds up. And the bulk of the work has been done in the US. They think that they may be mechanically vulnerable areas, possibly inflammatory vulnerable areas where tau protein builds up. We know that in different types of dementia, which simply means a loss of neurons over time, leading to dysfunction of a person's cognition. And this is a form of dementia. Alzheimer's is the most common. CTE is another subtype. So there is a gradual loss of neurons triggered by this buildup of head injury. It's caused by head injury. That's the overwhelming research now. So unfortunately, if someone has CTE, and it could be years after they retire, it seems that they are on a trajectory of typical dementia, albeit very slow very often. This is typically over years or decades of gradual worsening in memory, mood, and behaviour. So for memory, short-term memory is very often a trouble. Eventually, longer-term memory can be affected, or learning memory especially. Language memory can be affected. For mood, it's things like anxiety and depression, and they are very common, but we're talking again about decline and worsening over time and really prominent anxiety, depression. And then behaviour, so this sort of upwelling of anger is quite characteristic. So dysregulation or explosivity outbursts. So road rage can be there, or even just drop of a hat anger, like a minor trigger in the day. So somebody has said something that was interpreted as wrong to that person or unjust, and they might have anger just suddenly come out. Okay. That could be verbal outbursts or physical outbursts. So that's the pattern that we see. We match someone's history and how they examine and how they test on cognitive testing. with their brain studies and how they are over time to say, oh, does it fit this pattern or not?
So there is testing to there is testing that people can do to be diagnosed with CTE. Is that correct?
Yep. So it's provisional and it's only a likelihood, I guess, presented. Yep. So I work in dementia all day, every day. So I can use my experience and skills to A, rule out other dementia and B, rule in features of CTE. So it has to be done very carefully. I think this is in a subspecialist role where someone could be provided a possible or a probable assessment or diagnosis of CTE very carefully, because we don't want you know, too lenient diagnoses or alarmism to be there. But people come to care and they have a really marked history of head injury and then the other features that are very consistent. Well, look, it does look like CTE, and the reason we provide that probability is to get them to care and assistance. We're still revising that diagnosis every year as we see them, but we're trying to help them with symptoms. Yeah.
And if you are a lucky person and you are diagnosed with probable CTE, what next? Is there anything you can do?
Yeah. So I mentioned it's a really slow form dementia, it seems. So there's plenty you can do to prevent other things that would affect your brain health, worsen your brain health. So we do look at the vascular picture. So we'd look for blood pressure, cholesterol, all those simple things that can add up. We try and stop them smoking. We look at their alcohol history. Many patients do not have an alcohol background of heavy alcohol, but certainly we would want to minimize that where possible, because alcohol is a toxin to the brain. We would look for things like sleep apnea, so low oxygen in the brain at night that can affect cognition, migraine that can affect how well you're functioning in your cognition, anything that could mimic it or worsen memory, we will look for and target. Then there's the CTE symptoms themselves, knowing that we ultimately we can't slow it down or cure it at this stage in 2023. So we would try and boost memory. We can try some medication for that. We can try strategies with a team approach, multi-D team. We can also target mood stability, and really modify that behavioral pattern, the outbursts that they have. We're really quite good at that with our medication strategies and our team approach environmentally to help someone over time. And we support them and validate them. And that's really important for them, but also their families.
Yeah. I had no idea that there was anything that could happen once you got to that stage, because I guess the most I've heard about CTE over the last few years has been around the fact that it's identified after death, and usually they're relaying of their signs were there, but unfortunately not picked up at the time. So hearing that you can actually identify it through the right channels prior is amazing. It's great to see that that's obviously improving over the last 5-10 years. I'm going to swing right around back to the start and avoid head injuries. As I mentioned, I've got 2 daughters. They're into their dancing, gymnastics, and those type of sports. But I have a lot of friends that have sons and daughters playing more physical contact sports. The easy way to avoid head injury is not to be active, I guess, but it's not probably the way as a parent you envisage things going. Kids are always going to get hurt. My daughters are doing somersaults on the trampoline. There's going to be a time when you don't land on your feet. What can we do with our kids to help avoid any sort of long-term damage with brain injuries?
Well, look, I'm with you. Kids need to be kids. They need to be active. I was really into sport. I watched wide water sport every weekend, and I was out there playing my sport straight after, trying to replicate my heroes. You know, I taught myself to kick a footy and play cricket, and I was right in there. So yes, you could get a head injury. I mean, I've had a cricket ball hit me in the head, whatever. You could get a head injury through lots of things. My kids are active in sport. So it's not about restricting that. Obviously, we have common sense measures like, yes, you wear a helmet when you're cycling, and you want to climb a tree, but you don't want to climb 10 meters up the tree. Common sense strategies. The biggest thing that parents can do is, well, I think the biggest thing that needs to happen is we need to see the science in place for this. We need to see funding into research. So Australia needs to grapple with what problem they're dealing with, how big a risk of CTE we have, how much we have in the community. Potentially, we need some epidemiological studies. We need some really good strategies instituted right now for prevention. We need to work with the sports. Every individual sport will be different, and they're going to need, say, their own rules around tackling, I would suggest, because yes, you've got to learn that muscle memory, that safe way to tackle. What age is that? That's a tricky question. But then there could be consistency gained for avoiding or head injury in training to a certain age. Why do we need to head the ball all the time before a certain age? Do we need to, how much head injury risk do we need in training? Better recoveries after concussion, better rules around concussion. But as I say, it's that subconcussion burden. So do we need monitoring of our subconcussion burden, as in at least understanding how many years you played, having a comprehension and a consent for that risk, that medical risk? And we can't have our head in the sand around this, as has been the case. I don't want my, parents are now questioning, and myself included. I want to have this knowledge. I want better awareness and research in this space so that we can make better educated decisions, because the sports are going to go on, and that's a wonderful thing. But we need to see better strategies and prevention of head injury. So we need to work coming.
Sorry, Dr. Mobbs. Do you see that coming top down? Do you see the sports, the Rugby League, AFL, football in Australia sending down these protocols, saying if you're at grassroots, you can only start tackling at training maybe at 7 or 8 years old, but that won't go into games until a bit older? Because I've got a concern about starting tackling too late. I think that's going to cause way more injuries if kids were to start as they mature a bit more. And especially if you're not learning to tackle in a controlled environment, you're still going to watch State of Origin and go out in the front yard with your mates and try and tackle each other. So I tend to agree with you. It's just about being measured with how that starts. But does that come from the top down, or is that on a club level where each team or each club can manage? I mean, grassroots clubs now, they manage, okay, we start tackling at 7, but we don't play tackle footy till 9. How do you see that happening?
After 5 years of raising concern in this space, my optimism that it will come top down has diminished vastly. I think that in the community, there's concerns that are raised, and I think we have a much better chance of club level up. Grassroots making a difference here. I agree. There will be a level where we need to say, okay, at this age, you probably do need to learn how to tackle safely. As I said, it's not about elimination on that. It's about probably moderation, restricting the amount of tackling. You can learn to do it safely, but how much do you do it? And a lot of my league or union or any football, they'll say we actually played harder in training and got more head injury in training, and the data backs that up. 2/3 of head injury is occurring in training through volume or quality effort as well. Because you want to compete, you want to get your spot in the team, especially at the higher levels, and so you're in there. So what I would like to see, though, is we can't move forward unless the top down actually acknowledges an issue around subconcussion and starts talking subconcussion, because we've had everything about concussion, but we've had absolutely minimal around subconcussion. I would perceive, in my humble opinion. I think we can do a lot better. I understand there might be concerns around what this means for the sports ultimately, existential concerns, perhaps there's legal cloud and legal concerns going forward, but our kids are the most important thing. And if they're going to these sports now, we need to see the leadership working with the government to institute proper protocols going forward and structure scientific investigation for the next decade with proper investment, working with the sports around what they can do to minimize head injury, a much more proactive rather than reactive approach.
Terrific. Dr. Mobbs, it's been such a pleasure to have a chat to you. Like I mentioned at the start, I have been following you primarily through LinkedIn. You're very high up on my feed every time I log on now. But to have the chance to actually have a chat with you has been a real pleasure. I appreciate all the work you're doing there. Thanks. I think that's about it there, Carl. I can't think of anything else.
Thank you. It's been a pleasure as well. Thank you so much for having me, BK. And it's just good starting these discussions. It's the beginning, isn't it? So thank you for sharing all of your story as well.
Cheers.
All right. Thank you for that wonderful interview, BK, and for your responses, Dr. Mobbs. We've got both of them live now with us, ready to answer your questions. And there has been some questions that have been coming in, so we'll get started on those. If you've been holding off on your question, let us know. Now's a good time to throw it in there. You'll get a live response from the experts. So to kick off, we had Kay who said, can CTE be diagnosed before autopsy? She has a husband that's had several hospitalizations due to concussion and fractures in the early 60s playing football, and said that in those days they targeted the good players to try to take him out of the game. And since football, he's had a lifetime of neurological issues.
Yeah, so I guess I'll answer that. Hey, thank you for that question. Thanks so much to listeners out there. So yeah, I get this all the time now, and I'm pleased that there's awareness and questions around this. The targeted players, the really good players out there who played hard and were targeted, they tend to experience, in my opinion, experience a more severe syndrome of CTE earlier. I believe you can get a good understanding in life if someone has it, a probability that in medicine we aim for a 90% certainty, sensitivity and specificity we call it. So sensitivity is how early you pick it up and accuracy for picking it up. Specificity is how accurate you are that it is the case. You're sort of whether you've got false negatives and false positives going on, or whether you're certain and accurate you got it. And we're approaching that. I think there's lots of research on it now that will come forward, as I mentioned in my talk. But for now, you can use clinical expertise to say, it really looks like CTE. But in any case, in anybody with dementia overall, that's that big umbrella term, to say you've got a trouble with your neurons over time and a decline in cognition. We're really accurate at diagnosing that. You can be certain you got that. And we can help that. We can target symptoms. I mentioned memory in there. So there is medication such as a thing called donepezil or Aricept, Arazil. These are medications that can boost memory chemical within the brain. And so we can use those in a select fashion for certain patients to directly help memory. But really we can provide a scaffold of usual dementia care around someone who we think has CTE, and that can work wonders. Not always, but we certainly have to try and help these people.
You mentioned medications just then, Dr. Mobbs. Is there any medication that you shouldn't take right after you've had a concussion, or is there medications that you can take after you've had one to help?
So right after a concussion, one should be really wary about medication that could sedate you. So anything that might confuse your picture for consciousness, awareness, and really any decisions on medication should be made in consultation with that medical review, your medical practitioner, in that very early period, especially 24, 48 hours. So you must be very careful around that. There should be an early appointment within general practice, your GP, 1 or 2 weeks after a concussion, preferably in the first week. And then you ought to have follow-up at 2 to 4 weeks. I've just been meeting with the concussion guidelines group this week, actually, and these are the sorts of discussions, so more close, intense monitoring. So there's a bit of a heads up. So you want sort of those early appointments in place. You don't want to be one of the people who are lost follow-up and develop symptoms and have a delay in care, because that can lead to a worse outcome. And it's things like medication confounders having adverse effects to that, or medication interactions, for example, that can really lead to worse outcome and complicate things.
Yeah, I mean, I found during my soccer season that I would just bruise a lot more easily because I had I'd take daily aspirin for migraine prevention. I can't imagine that's probably a good thing to have when you have a concussion and you're worried about a bleed in the brain. If you have a drug that facilitates bleeding, more easily, you probably want to avoid that.
Yep. So again, within that 48-hour window, we're careful. If you're older, so perhaps over 65, you are at a higher risk of bleeding, perhaps even not within the brain, but around the brain. Sometimes subdural hemorrhages can occur from the little veins around the brain. So you do want to be careful, if you're on a blood thinner, but you should continue to take that until you're advised not to. I mean, that needs to be in consultation with your practitioner, as I said. Aspirin outside of that 48-hour window is safe for most. But obviously, if you're older, you need to be a bit more careful around that. And if you have a decline in that cognition and increasing sleepiness or confusion that comes on, and that's going to be those around you that will tell you, and that could be 2 or 3 weeks later after your concussion, that's a red flag, and you have to be rescanned and looked at for subdural hemorrhage if you are in that older category, especially.
Next question is for BK. If you had the opportunity to speak to a team of professional or semi-professional athletes, knowing what you know today, what would you encourage them to do when it comes to managing a big head knock that occurs during the game?
That's a good one. I hadn't really thought of it. I think just being open with anything that you're feeling. So you have to be open with your feelings to the medical staff. I feel that was probably something in the past that was kept to yourself. You didn't really show any weakness, so to speak. So if I was speaking to a team today and we were discussing what to do if you do feel some sort of effects, it's be open. And maybe not even just with medical staff, maybe with teammates, family and that afterwards, because as Dr. Mobbs has said many times, it's the people around you that will really be able to help. So I think, as I touched on in the interview there with Dr. Mobbs, I probably wouldn't have really thought too much about the after effects of the concussion in the UK if it wasn't for the silly lamp episode, which became a joke in the end, but quite a scary one looking back.
And I would imagine it's a difficult balance to strike, because you've got every incentive as a player to have that game time, to be on the field, to be performing to the best of your ability. How do you encourage people to see kind of that short-term sort of opportunity versus the long-term sort of repercussions of, making the wrong decision at a time when they've been, they've had a head injury or a concussion?
Again, I think the openness now, where we're seeing a lot of ex-players coming forward with the effects, I think they're telling the story for the young players. Yes, it is rewarding being on the field the next week for many players, but even players that are still in the NRL now who have had knocks and had to go overseas for treatment and identification of what's going on. A short-term gain is not going to help you long-term. And I think that, again, going back to the openness there, not just internal, but the codes themselves have been a lot more open about it. And that's what will end up helping in the next few years.
We had a question from Ansley, Dr. Mobbs, about whether someone should go over their previous head injuries with their doctor, even if it happened 5 years ago.
Oh, I think that's a great idea. Why not have a brain check? For some people, it's a memory check. If we're talking dementia, some people come in proactively for their risk of dementia in the future. Say if their parent has dementia and they want to know, what can I do now to improve my brain health? That's a very reasonable appointment, I would say. And so recapping your total cumulative head injury history, and remembering that subconcussion burden. So what age did you start play? What age did you finish play? Did you miss any seasons? And then there's that concussion history. And I often say to my patients, my definition of concussion is any symptoms after a head knock where you weren't right. Confusion, stars, dizzy, whatever. Doesn't have to be a knockout. How many have you had? And when you give that little entree, it's not just the 1 or 2. Oh, it might be 10 or 20 actually, doctor. So that just gives you your estimate. What we're looking to now, I guess, with the Senate recommendations, we haven't touched on those yet too much, but perhaps concussion passport, concussion monitoring, like radiation monitoring, some sort of way to kind of know your total history. It's not going to be a perfect measure, obviously. It's hard thing to detect and measure and keep track of in life, but we could gain some insights and estimates for individual risk. And then this call for a national sports injury database. So that's going to tally up the data of which cohort of person is at what risk of what illness. And that's going to guide and drive national policy going forward, and then feedback in the protocols. And I imagine we'll get technology improving all of this. We'll get apps, we'll get, websites, we'll get monitoring stuff like accelerometers, and that might be mouth guards, helmets, etc. So it's quite exciting where this can go. Of course, it'll take time, probably the next decade's work, hey?
Yeah, but that's pretty exciting. Like, imagine if you're wearing like a soft helmet, which is common in football, that it has a built-in accelerometer. It can kind of give you a proxy on what kind of concussion or head injury you just sustained and how serious it might be. Like, it's pretty advanced. I mean, we're doing that with health and fitness and tracking with people's vests, right? That track their mileage on the pitch.
Yeah, so the latest paper out of Boston looking at the NFL players, American football. So they leveraged accelerometry data, so existing data for players in different positions, and they could say, well, in this position, linebacker, I was like, oh, what's a linebacker? I had to read up on it, but a linebacker, that is at a high risk of CTE. And they could correlate it with length of play and the number of hits plus the force of those hits as to your increasing severity of CTE and the likelihood that you would get it in the first place and the earlier manifestation of it. So there's quite clear data on that subconcussion burden. Yeah,
that's really interesting. Jane had a question asking if CTE shortens your life expectancy and how many big concussions is too many?
Oh, I don't like the tough questions in this way. It's sad, isn't it? It does shorten life expectancy because it's a form of dementia. Dementia is named to be, one of our top health issues and targets in Australia. Of course, we've got that big Alzheimer's vascular burden. As we live longer, many of us are facing dementia. So it's a big issue all round. Resources have been thrown at it left, right and centre, both nationally and internationally on this. I would encourage you to also remember Dementia Australia as an excellent resource in that space. But unfortunately, it does lead to dementia, leads to decline, troubles with frailty, falls and needing higher care. And many of us are familiar with that from our Alzheimer's relatives and so on. And that's, a very sad thing. In terms of CTE, it's a very, very slow form of dementia. So often over 20 or plus years, as opposed to Alzheimer's, which is more a 10-year type of pattern. So it's A, hard to recognise, B, you're in for the long haul, C, you've got these tricky kind of different niche symptoms that need subspecialist care. So it needs its own unique set of team care and niche care requirements put to it, and investment in care and research, I would say. Then you asked on the number of concussions, did you, as to relating to CTE? Of course, it's not about the number of concussions. For every concussion you have, you actually could have 80 plus, 100 plus subconcussions that are more force than what you had to sustain your concussion. It's just that you didn't get symptoms with it. So you get microscopic changes in the brain at a higher force, but it just happened not to give you a symptom at the time. So that's the trouble.
Rachel had a question about her 16-year-old son and whether, if she could figure out how to tell whether he has CTE because he's had 4 concussions in 4 months and he's started to get headaches and seems like he's forgetting things.
No, so we're not talking about teenagers. That said, there are very, very rare cases worldwide, but that's a very high impact situation. I think there was a rodeo rider at 25, for example, with it. I don't want to see alarmism in the community about teenagers or youth having CTE. I think that's highly unlikely. It is a young form of dementia, but when I say young, I mean, it's still very young. Hey, I'm talking about 40s, 50s, 60s. Where I typically have patients who present in that category, still far too young. But I don't want parents to panic, and it's not related to this handful of concussions. The Americans have clear data that it's more when you start to enter the college levels, so university levels up. Not that we should quit sport necessarily, I add that caveat in, but that's when you start to enter perhaps that higher impact and higher risk category for CTE. And of course, if you're a top level league player or whatever, you play till 30, 35. And then if you decide to box after your career, that's probably not the best idea. And you're at a high risk of CTE.
Bernie said that he's got a son at a concussion clinic at the moment, and he's been there sort of 4 weeks treating symptoms. But he also has lived in a regional town and said that this would be impossible if he was in the regional Australia. How is concussion protocol going to be accessible outside the cities?
Yep, big focus on that. Well aware of the issue. It is a bit of a wicked problem in that simply in Australia we can't extend resources to everybody everywhere. That's just not possible. However, COVID's afforded us the advent of telehealth. So I think that is being utilised very well. I'd encourage you to think about that. You can reach out not only to your local metropolitan centre, your city, for telehealth, but you could reach even interstate now and have those appointments. And it's not going to be perfect necessarily for all appointments, having physical examination is important, but that is a resource to consider. In terms of managing it directly, on the ground in the country, well, that's very tricky. This is where we need really good guidelines that are consistent and clear, that we can train anybody around a patient, so be it a parent, a coach, just a spectator, to recognise and manage concussion very well, especially in that early phase. And then we can reach out to GP and telehealth and specialist care down the track.
BK, this is obviously a topic that you're quite passionate about. What made you kind of step forward and want to be an ambassador for the Brain Foundation and Migraine Headache Australia?
Probably the fact I just realised how little I knew. As I touched on with the chat with Dr. Mobbs, I thought my head injuries where I'd had operations were concussion. I didn't really understand what concussion was, and there is more light being shed around it now, which we've said is great. And as that came out, I was like, I know nothing about what's happened to me to date. So that's been the big reason. And obviously, the timing is great with what's happening in the Senate. And that I really feel there's an opportunity to keep sharing my story there to assist with the growth.
Patrick had a question for Dr. Mobbs. Does wearing helmets, such as in American football or like ice hockey, or skull caps, like soft helmets, make any difference to the risk of damage caused from concussion?
So there's actually some evidence that the American helmets might make it worse. You've got an increased weight, you've got centrifugal forces, you've got reduced awareness, and you've got a gun-ho kind of superhero aspect. You know, you feel protected by your helmet, especially for younger kids, perhaps. So no, and in terms of directly for your brain strain risk, so your shaking of the brain, like a bell ringing within the skull, it doesn't change that. It might stop you having a fracture, might stop those really big kind of bleeds within the brain. So it's probably a good idea, of course, if you're a jockey or an Olympic cyclist or whatever, you need your helmet. But headgear and helmets otherwise, not necessarily a good thing, and it's not something I actively suggest and advocate for. That said, it is a focus of some people's research, and perhaps there will be technology coming through where we have a whiz-bang helmet that's going to reduce concussion rates but what we really need is reducing microscopic injury in the brain, not necessarily concussion symptoms, and that's yet to be seen with the biomarker work that we don't yet have through yet. So, you know, it's going to be this sort of long haul, 5, 10, 15 years of research to understand that question. Yeah.
Something that the Senate report revealed was that soccer by participation was the largest sport in Australia. Patrick had a question about frequent heading of the soccer ball. Does that increase the risk of cumulative damage?
It does. It's still a force hit to the brain. So there is data around that. There has been for a long time, especially if we look back to the old style leather balls. They were heavier. There's still forces, and even if you have a faster, lighter ball, it's still perhaps the same force hit to the head. But the old leather balls, especially if it was raining and wet, but they were thought to have, you know, significant head injury potential. I actually had a couple of patients who do look to have CTE who were in the UK back in the 60s. They used to string the soccer ball up in their garage and head it 200 times a day as training. So there are cultural aspects as well as physical aspects to that sport and how it was played that might be different now as far as risk. Just broadly, I guess if I look at the sports and the major codes, I sort of think, well, and I know from the type of patients I see, well, one of my research questions is, could AFL and Rugby League and Union perhaps have a higher risk than soccer? It's interesting, and some of the data would back that up to suggest that soccer is perhaps a lower risk, a notch down.
It's interesting. Jane had a comment about like kids playing sports like football, where the kids' weights can be so different at young ages. You can have a 40-kilo kid up against an 80-kilo kid. Do you have any thoughts about whether we should be focusing on weight classes versus age, like, you know, age classifications in sort of those types of sports?
Definitely. So it's that's called biobanding. So getting weight for weight, I understand. And I think that's really, really important. The argument as well is also development. And I'm not a pediatrician here, so I declare that I'm not an expert in this. But I hear from my pediatric neurology colleagues that, of course, the brain frontal development is important, their ability to make choices on the field appropriately, tackling choices, let's say, and safety on the field. So you have to kind of neurologically, neurodevelopmentally band as well as bioband, and I'm not sure where that balance is going to be had. So this is where it's exciting that we see these Senate recommendations for this complicated long-term research that's clearly going to require a lot of money to sort of let this science come through and help tell us that.
BK, do you have any thoughts about taking into account neurological development of kids plus their weight and then classifying them into teams and groups and leagues?
Not really. I am concerned. You touched on an 80-kilo kid there and a 40-kilo. I'm 80 kilos myself. Obviously, a lot of difference between me and a 12-year-old that's 80 kilos. So, yeah, it's not something I've really put much thought into, so I probably couldn't really add any significant information.
We've had quite a few people that have talked about their own injuries, that have had car crashes or concussions themselves. If they're concerned about their own health and well-being, where can they go to find out more information or get tested for, CTE or the symptoms?
Yeah, so you start with your GP. You'd have that discussion around a memory check. It's memory, mood, and behaviour. They're the key features that I talked about in my presentation with BK. You can consider then discussing with your doctor on a specialist referral, and it may be a neurologist. I'm a cognitive neurologist, so that we are even more subspecialist in dementia. But then you also have neuropsychiatrists, so they are subspecialist psychiatrists who work in dementia the same that I do. Then you have geriatricians who work around dementia, or you have rehabilitationists, neuro rehab specialists who could equally do that. And some GPs focus on dementia. So I think it's a matter of finding that expert care wherever it can be found. And obviously there can be things like waiting lists, resources, and access to that specialist care. But certainly considering working within a team for that subspecialist care would be ideal if you're going to look at these sorts of questions. Until we have better testing, we're all after those biomarkers. And what will be most ideal is getting 1 or 2 tests, perhaps it will be a panel, 3 at most, of say brain scan plus neuropsychology testing or something that can be clear, come up to that 90% sensitivity or specificity or more, and say this is you have CTE. Even something perhaps that non-specialists could use. That would be ideal to have that sort of technology come through, but we're not at that stage.
Yeah, a quick screening tool would be very helpful.
It would be lovely, wouldn't it? Just magic. But no, we're not there yet.
Dr. Mobbs, BK, thank you so much. This has been a fantastic conversation. We're very privileged to have you here on behalf of the headache and migraine community. We really appreciate you spending your time with us today.
Oh, thank you so much for having us. It's been great to talk.
All right. Bye-bye.
Thanks, everyone. See you.